Okay, whenever ready. All right, so we're going to try a case presentation today. As I did the last time I was here, I always show a picture of my family. So that's my wife and daughter. This is Washington University. That's where I did my training, and as you can see, it's very, very big, which is not good for walking. From one side of the hospital to the other, it's almost half a mile. So if you get called on a consult, you walk half a mile, and then you come back a half a mile. So that's a mile just to go back and forth. And then usually what happens is by the time you're back, they'll call you for another one, so you got to walk back. We don't have any fat fellows there. Okay, so we have a 49-year-old female who presented from an outside hospital initially with, she had initially come in with jaundice and periumbilical abdominal pain for about 3 days. She was transferred because of these labs. As you can see, she definitely has some liver injuries there with AST, ALT that are elevated, mostly with the AST, and her albumin was very low. Initially, her creatinine was okay, though, but the main, the main problem was the bilirubin, 16.6. On review of systems, she had nausea, abdominal pain, worsening dyspnea on exertion, lower extremity edema for about 3 weeks. And her past medical history includes hypothyroidism, asthma, and nephrolithiasis. She's had some surgeries, gastric bypass. She had a cholecystectomy, a C-section. In her family, she has a history of brain tumor, CVA, and hypertension. Her social history, no smoking or drugs. However, she is a heavy alcohol abuser. Vitals show that she had a low blood pressure, 96/50. Rest of the vitals were okay. On physical exam, she had some scleral icterus. She was heavy, and so it was difficult to assess any lower extremity edema. She also had jaundice in her skin. The medications that she was on at the time I saw her, she was on albumin, Cipro, heparin, lactulose, and levothyroxine. And those are her allergies. These are the initial labs that we got when we got the patient as a transfer. Her sodium was low. Her creatinine had gone up. Initially at the outside hospital, it was 0.9. By the time she got to our hospital, it had gone up to 2.99. Hemoglobin level was low. They had calculated the FeNA, which was very low. They checked the UA, which did show a urinary tract infection with cultures that grew E. coli. We also did an ultrasound, which was essentially normal. We also got an echocardiogram, which was positive for diastolic dysfunction. We did a liver workup initially due to that elevated bilirubin. The ultrasound was negative, but it was difficult to assess due to the amount of fat that she had. And so we ended up doing an MRI, which was significant for hepatic steatosis. And so we moved on to a biopsy, ultrasound-guided biopsy, and we also did a paracentesis, which was negative for SPP. We sent some initial labs, ANAs, anti-mitochondrial antibody, anti-smooth muscle antibody, ceruloplasmin, all of which were negative. Her SPEP was essentially normal. CMV was positive, but that was just the antibody. When we got a PCR, that also came back negative. We got HCV antibody that was positive, but again, same thing. When we checked for an RNA, the RNA was negative. As I said, we did get the results for that biopsy, which was essentially consistent with steatohepatitis. And so we diagnosed her with alcoholic and also steatohepatitis. We started her on prednisone for about a month. She was initially given some volume expansion for a couple of days, and we did that with some albumin, IV fluids, and we also treated her for the urinary tract infection. Thank you. Sorry, guys, I have a cold. All of which failed to improve the creatinine level. Hepatologist's recommendation was to do octreotide and midodrine, which I agreed with, and we started it. The problem was that she wasn't a candidate for a transplant because of her previous alcohol use right before she was admitted. Her urine output dropped over the next few days, and her creatinine continued to increase. It went up to 4. She became even more volume overloaded. And we made the decision to start her on hemodialysis. Now you'll see as we go on and talk about this case that you could have easily made the decision not to dialyze this patient. And we'll talk about this later on. We continued dialysis for about 12 days, and by day 10, her urine output had actually recovered. She started making over a liter of urine, and we did a 24-hour urine collection, which showed a creatinine clearance of 55. So she had recovered essentially kidney function, and we took her off dialysis. By the time we sent her home, her creatinine had come down to 1. Basically, as you have guessed, the diagnosis that I gave her was hepatorenal syndrome. It's a reversible functional renal failure. And what I mean by functional renal failure means that there is no anatomical problems with the kidney. It's a functional disease. And it usually happens, by definition, it happens when you have liver disease in the setting of ascites and portal hypertension. There are 2 forms of this disease, and it's based on the progression of the disease, how fast it happens. There's also a pseudohepatorenal syndrome. And pseudohepatorenal syndrome is not really a diagnosis. It's basically any disease that you have that simultaneously affects your liver and your kidney at the same time. But you have to, it's essentially a diagnosis of exclusion. Here's the definition. So there are 2 types, again, type 1 and type 2. And again, it's all based on timing. For type 1, you have to have a doubling of your serum creatinine to above 2.5 or a 50% reduction in your 24-hour clearance. And that has to happen within a 2-week period or less. This usually follows a precipitating event, which usually includes SPP or something else that happens acutely. The median survival is very poor with type 1. It happens quickly, and people die quickly. Within 2 weeks, most people are actually dead. Type 2 is longer. It's less rapid deterioration of your kidney disease, and it happens over several weeks to months. It usually presents itself with refractory ascites, and it has a much better survival, about 4 to 6 months. But again, 4 to 6 months, that's still pretty poor. So regardless of whether you have type 1 or type 2 hepatorenal syndrome, your prognosis is going to be very low. So what's the pathophysiology here? You have renal disease that is caused by hypoperfusion. You just don't get enough flow. And that usually happens because of renal vasoconstriction in the presence of splanchnic vasodilation. And what we mean by vasodilation of the splanchnic vasculature is that's going to lead to a low mean arterial pressure. So you have an increase in your plasma and urinary levels of vasoconstrictors. Why? As I said, your splanchnic vasculature is vasodilating, so you have to compensate for that. So your body releases vasoconstrictor. What are them? What are those? It's usually your renin levels go up, norepinephrine, neuropeptide Y, arginine vasopressin, endothelin, F2 isoprostanes, and also some urinary cystinyl leukotrienes, all of which will cause vasoconstriction in order to compensate for the splanchnic vasodilation. And we'll talk about why you get this vasodilation in the splanchnic vasculature. So you get an increase in your level of vasodilators also. You get endotoxin, an end product, nitric oxide, glucagon, and that is the reason why your splanchnic vasculature dilates. And again, I'll show you some pictures which will hopefully help you make sense of this. So what happens in the splanchnic vasculature is that you get endotoxemia. The reason, and you also get some shear stress during liver failure, and that's because when you have liver failure, you get portal hypertension. So the pressure inside of that vasculature goes up, and you cause some shear stress against the walls. And this causes a decrease in your systemic vascular resistance. However, as I said, you're at the same time releasing vasoconstrictors, and so initially your mean arterial pressure doesn't change that much because you also have an increase in your cardiac output. The splanchnic vasodilation leads to decreased effective arterial blood volume. What that means is that you have, most of these patients are edematous, right? They have a lot of fluid, so their total volume is up, but the amount of actual flow into the kidneys has gone down, decreases. You have essentially the same thing that you see in cardiorenal syndrome. You have too much fluid, but the actual amount of fluid circulating in the vasculature is down. So you get a resulting sodium and water retention, which essentially worsens your ascites, and so that's why they keep on retaining more and more fluid as they go. Because of this decreased effective arterial blood volume, your kidneys think that they're not getting enough volume, and you're, in essence, it's as if you were hypovolemic. You don't get enough flow, the kidneys try to compensate. The way they do that is by retaining more salt, retaining more water, which then worsens the initial problem, which is fluid overload, ascites, and that's why the prognosis is so poor, because they just keep on getting worse and worse. The vasodilation and vasoconstriction try to compensate each other, but at some point you have a tipping point. The heart starts failing. Remember, I told you initially the heart tries to compensate by increasing cardiac output, but at some point it's no longer able to do that. And so because your preload is going down, your mean arterial pressure continues to drop. The stimulation of your vasoconstrictors keeps going up to compensate, but again, there is a tipping point. And then the balance between the systemic and vasoconstrictors is lost at some point. So here's a picture to try to explain to you what happens, why you have the vasodilation in the splanchnic vasculature. As I said, for one, you get this shear stress against the walls because of the portal hypertension. So that causes vasodilation. At the same time, you have translocation of your gut microbes, which come in and release endotoxins. The endotoxins then cause vasodilation. It's the same thing that you get when you're in septic shock. Why do septic patients go into shock? Why do their blood pressures go down? It's because of this endotoxin release, which causes vasodilation. Mean arterial pressure goes down. Same thing here. Initially, your cardiac output goes up, you compensate, and you also release those vasoconstrictors that we talk about. But at some point, you can no longer compensate, and that's when your GFR starts going down, and your mean arterial pressure obviously is down. Okay, so here you can see, initially, take the top line, which is your cardiac output. Initially, your cardiac output goes up, tries to compensate for this decreased effective arterial blood volume. Cardiac output goes up, but there's only so much the heart can do. So at some point, it levels off, and it is no longer able to maintain that cardiac output or increase the cardiac output. You can see the splanchnic arterial vasodilation just keeps getting worse and worse and worse. The resistance goes down and down and down. And then your extra splanchnic vasoconstriction to try to compensate for this vasodilation keeps going up and up and up. And you can see at the bottom here that ascites doesn't happen until towards the end, and then towards the end of the disease you end up with hyponatremia, and that's when you start getting towards the end, when there's really no more compensation, you get your you get your hepatorenal syndrome. This is an angiogram of a patient in hepatorenal syndrome, and it's there to show you that there is decreased flow to the kidneys because of the vasoconstriction. So there is vasoconstriction of these arterioles inside of the kidney. Look at the difference when the hepatorenal syndrome resolves. Same patient. See the vasculature now? Much more blood flow into the kidneys because that vasoconstriction that was there to compensate for the vasodilation in the splanchnic vasculature is now gone. Now you're bringing enough flow into the kidneys. So drastic change there. This is the same patient, same kidney. So what's the epidemiology? People are always surprised when I give these numbers. It's actually pretty frequent. Hepatorenal syndrome develops in 18% of cirrhotic patients within a year. But if you look at 5 years, almost 40% of them will have at some point hepatorenal syndrome. So it's pretty frequent. So there are some predictors that you can look at. Low sodium, again, remember this chart. Hyponatremia happens towards the end, almost at the same time where you would expect hepatorenal syndrome to happen, because it happens towards the end of the disease. Why are they hyponatremic? Again, decreased effective arterial blood volume. You don't get enough blood flow into the kidneys. Kidneys think you're hypovolemic, try to increase your fluid status. How do they do that? Two ways. One, they try to reabsorb salt. The way you do that is by releasing renin, which then causes the release of aldosterone. You retain more sodium. You retain more sodium. Wherever sodium goes, water goes. So that's number one. The other thing is you're also releasing ADH, antidiuretic hormone. Antidiuretic hormone only reabsorbs water. Because you're reabsorbing water and not sodium with it, you're reabsorbing more water than sodium, so guess what happens to your sodium level? It comes down. Remember, problems of sodium have nothing to do with sodium. It has to do with the amount of water, right? So that's why, because their ADH levels are elevated, and so you're retaining all this water, which then brings down your sodium level, causes hyponatremia. There are some precipitating factors, especially for type 1. Remember, that's the type that is the acute one, happens within a couple of weeks. By far, the most important one is your infections, which is your SBP. GI bleeding, however, can do it if you use excessive diuretics. Because again, you already don't have enough flow into the kidneys. Now you're diuresing them and taking more fluid off. Guess what happens with the actual amount of blood flow into the kidneys? Goes down. Also, if you do a large paracentesis, large volume, this is why we give them albumin, to try to compensate for the fluid you're taking off so that your effective arterial blood volume doesn't go down. And then NSAIDs. Why NSAIDs? Again, not enough blood flow into the kidneys. Now you're giving them NSAIDs, which cause vasoconstriction of your afferent arteriole. So not only you don't have enough blood flow coming in, but now you're causing vasoconstriction of the artery that brings in the blood. And so now you get even less blood flow into the kidneys. Therefore, GFR goes down. So that's the pathology. Remember at the beginning we talked about the fact that hepatorenal syndrome is a functional disease, not anatomic. So what should you expect on the pathology slides? Nothing. It's a functional disease. There is nothing wrong with the kidney. It all has to do with the amount of flow into the kidneys. So you get a biopsy, guess what? It's going to look normal. How do you diagnose it? Well, you need a serum creatinine, which is what we usually use, right? You have to be very careful here. Creatinine is not always appropriate here, and the reason is because it estimates the actual renal function, because there is decreased production from the liver. You have liver disease, and so you would expect their creatinine levels to be low. Also, they have decreased protein intake. Most cirrhotic patients don't eat very well. And they're also not producing the protein. And also, these patients have muscle wasting. Where does your creatinine come from, right? So they have low muscle, they don't eat enough, and they're not producing enough protein. So you expect their creatinines to be lower than a normal person. That's why it's not always the best test, but it's what we have. The creatinine level is also artificially raised by some medications that we use, such as your cephalosporins, which is your go-to medication. Ceftriaxone is what you use for SBP, right? and that can artificially bring up your creatinine level. There are other things that we can check, like cystatin C, but it also has some limitation in cirrhotic patients. So you run into the same problem. And then when you check the calculations, the Cockcroft-Gault and the MDRD, they can overstimulate GFR in cirrhotic patients because, again, your creatinine level is not very accurate. So if you use a creatinine cutoff of 1.5, which is what most labs use as an abnormal level, you're going to miss many of these cirrhotic patients with an acute kidney injury because their creatinines are lower at baseline. Even if they go up by 0.3 or more, you're not going to see a change over your abnormal levels in your lab. Initially, they had come out with some diagnostic criteria. This one came out in '97, and look how long it is. They tried to make it a little bit more simple, so they came out with another one in 2007. This was the International Ascites Club that came out with these criteria. They tried to make it a little bit easier to diagnose. The other major difference between the two was the fact that in the old criteria, you could use albumin or normal saline IV fluids to increase the volume. However, when the revision occurred, they went with albumin as the initial volume resuscitator. And you have to use at least 2 days, 48 hours of albumin before you can diagnose someone with hepatorenal syndrome. You also have to have absence of shock, obviously an elevated creatinine. You shouldn't be on any nephrotoxic medications. These are all pretty self-explanatory. There's also has to be an absence of parenchymal kidney disease. So if you see proteinuria, you have to look at other problems. Or if there is red blood cells, because you wouldn't, remember, it's a functional disease. You shouldn't expect any protein excretion or any hematuria. So that's why we get a UA. Any cirrhotic patient that you think might have a hepatorenal syndrome, you definitely need a UA. So I told you how poor the prognosis was. So the important thing here is try to prevent it. How do we do that? Well, you try to prevent large volume changes, volume contraction, which can occur in several states. So if you have GI bleeding, you lose fluid. If you have lactulose with diarrhea, excessive diuretic use, or large volume paracentesis. Now, lactulose, this is something that bothers me because someone comes in, you diagnose them with cirrhosis, and you think they might have some encephalopathy. You start them on lactulose 3-4 times a day, you send them home, right? And guess what? They keep taking it that much because that's what the label says. You have to titrate it based on the amount of bowel movements they have. Once they have a couple of bowel movements a day, you have to back off on that lactulose. Otherwise, this is what you're going to end up with. They're going to have volume contraction. They should also be advised to adhere to a low-salt diet, which is less than 2 grams. Now, everyone knows that, right? The average American diet has about 6 to 8 grams of salt in it. So we're eating about 3 times the amount that we should. And that's obviously going to help with edema, right? The less salt you take, the less edema you're going to have. Remember earlier I told you water has to do with the amount of salt that you have. And it's the same thing. The amount of salt that you have in your body has to do with the amount of water. Okay? How do we treat edema? Well, the 2 main drugs that we use is Lasix and spironolactone. Usually the spironolactone, you start it low and then you titrate up. You can go up to 400 milligrams a day, which is a lot of spironolactone. You have to be careful with your potassium levels. But that's why these patients are also on Lasix. You initially started at 40 milligrams, and you can titrate it up to 160 milligrams a day. Usually the way I do it, for every 40 milligrams of Lasix, I use 100 milligrams of spironolactone. Now, a lot of these patients are resistant to diuretics, and they end up with paracentesis. But remember, if you do a paracentesis, remember to give them some albumin to try to compensate for that volume that you're taking out. So for every you give 8 grams of albumin for every liter of ascites that you take out to prevent hepatorenal syndrome. Also, SBP, you should treat it right away. Remember, it is an initiating factor for hepatorenal syndrome, especially type 1. And so you have to get on it right away with antibiotics. And usually, as I said, we use ceftriaxone. And the second part of this, which not most people don't do, is to add albumin. You have to add 1.5 grams per kilogram initially of albumin, and then another 1 gram per kilogram 2 days later. And this is actually shown to decrease the amount of hepatorenal syndrome during the SBP. Now, prophylaxis for SBP. With people that have frequent SBPs, you can put them on norfloxacin. Not only does it prevent SBP, but it has also shown to delay in the hepatorenal syndrome in these patients. It also helps improve your mortality benefit. Pentoxifylline has also been shown to reduce your risk of hepatorenal syndrome. And the way it does that is by, it actually inhibits your TNF alpha. So we talked about how it presents, how you diagnose it. Let's talk a little bit about its treatment. Once you've diagnosed somebody with hepatorenal syndrome, you should start the workup for an orthotopic liver transplant. Again, we've said it multiple times now, it's a functional disease. There is nothing wrong with the kidneys themselves. If you fix the liver, the kidneys will respond. If you do it within a reasonable amount of time, and we'll talk about this, timing actually does make a difference. If you know someone is a dialysis candidate, if you know someone is a liver transplant candidate, you can start dialysis as a bridge. You start them on dialysis until they get the liver transplant, at which point you expect the kidneys to get better, and then you're going to stop dialysis. The problem is, what do you do with people? Because most of these people come in, they're alcoholics, they're not liver transplant candidates, or they're either alcoholics or they're too sick. So what do? You can start dialysis, but remember, their prognosis is so poor. You're not going to change the mortality, right? Eventually, they're going to die from their underlying problem, which is the liver, not the kidneys. So usually, my question is always to the GI doctor, is this patient a liver transplant candidate? If they say no, then there is really no point in starting dialysis. Your main focus, what you're trying to do here, is trying to reverse the splanchnic vasodilation. Because essentially what you're trying to do is increase the effective arterial blood volume. You're trying to bring in more flow into the kidneys. How do we do that? Well, we already talked about albumin. Very important, right? You also use vasoconstrictors. Remember, you're vasodilating, so you got to bring that vasodilation down to increase your mean arterial pressure. So we use vasoconstrictors. Now, most of the attention has been given to terlipressin. Problem is, it's not yet FDA approved in the US. It is used in Europe.
Just vasopressin, sorry.
You can. Yeah, we'll talk about those. Norepinephrine especially too. So there has been studies, actually the last one came out just at the end of 2015, which again showed that terlipressin does work. The problem is mortality benefit, and I think I have some slides on that. Mortality doesn't change all that much, even though your kidney function improves on these medications. So we don't have terlipressin here. So instead what we use is midodrine and octreotide to cause vasoconstriction, bring blood pressure up, try to perfuse the kidneys a bit more. There have been several randomized combination of terlipressin and albumin, and it has been shown to, again, reverse hepatorenal syndrome. But as I was telling you earlier, the issue is the survival benefit. It doesn't really change. Sorry about that. If a patient does not respond, though, to the treatment, there is really no point in continuing these treatments. You should stop it after 4 days. Remember, they're vasoconstrictors, right? What happens when you vasoconstrict your ICU patients for a long period of time? They start losing their digits, their fingers, toes start falling off, necrosis. Because of that vasoconstriction, you don't get enough flow into your capillaries. So it's not something you want to continue if you're not getting a good response. Now, terlipressin, you have to be careful because it is contraindicated in ischemic heart disease. Why? I mean, it's obvious, right? It's a vasoconstrictor. Or also people who have peripheral vascular disease and cerebrovascular disease. Now, as I say, it's not FDA approved yet, but it will be because all the studies have been pretty positive with terlipressin. So it's just a matter of time. So here you can see the difference between terlipressin and placebo, and you can see the decrease in your creatinine levels. It's definitely, as you can see, helpful. The issue is here, is when you look at your survival. There's really no difference between terlipressin and placebo. There is a small change, but it's not statistically significant. So we have terlipressin, vasopressin, norepinephrine, midodrine, and octreotide. So this answers your question, right? They're all vasoconstrictors. They all work. The nice thing and the reason why I use midodrine and octreotide is because they don't have to be in the ICU. The other good thing is the amount of vasoconstriction that you get is not as strong, and so they don't end up with the same problems as you get with pressors, with the whole ischemia. Most doctors use the combination of octreotide and midodrine as opposed to one of the other ones. But if someone is already in the ICU, by all means, you're more than welcome to use vasopressin or norepinephrine. You can offer a TIPS procedure. However, it does have a high mortality, 1 to 2%, and morbidity is high, about 10%. It can lead to bleeding, cardiac arrhythmias, the shunt can migrate. There's a lot of problems that you can get with TIPS procedure. The other thing is also there is worsening of your hepatic encephalopathy because now all those levels, instead of going through the liver and being synthesized, go straight into your brain, the toxins. Now, the TIPS procedure has shown to improve renal function in refractory ascites. So it is helpful in type 2 hepatorenal syndrome. The problem is, same thing as terlipressin, is the survival. It doesn't seem to make a difference when we look at survival. And I think all of these studies are consistent. It does help with the kidney function. Their kidney function does improve, but at the end of the day, you're not dying because of your kidney disease. You're dying because of the liver disease. That's why everything that we're doing here, at the end of the day, doesn't change a whole lot when you look at survival. The main thing, you gotta get them a new liver. Liver transplant is your main goal here. Now, the TIPS procedure, you should know there's some contraindication. So if someone has severe liver failure, or if they have hepatic encephalopathy or cardiopulmonary disease. Dialysis is something that we do offer. Obviously, peritoneal dialysis is not an option here, right? They're already fluid overloaded with ascites, and now you're trying to add more fluid into their abdomen. It's just not going to work. So we're only talking about hemodialysis here. It is difficult to do intermittent hemodialysis in these patients. The reason is, even if you take a normal person without any liver disease, most people's blood pressures tend to go down during hemodialysis. These people already have hypotension to begin with, and now you're causing even more hypotension during dialysis. It's very difficult to treat them. Now, in the hospital, that's one thing, right? You have albumin, you have nurses, you can always transfer them to the ICU, worst case scenario. How do you do that when you're sending someone home to an outpatient dialysis unit? It's a nightmare. That's why, again, the people that you select to start on hemodialysis, you have to be very careful. I'll tell you what I usually do. I told you earlier, I usually ask the GI doctors if this patient is a transplant candidate. Yes or no, right? Pretty easy. But the people who are not dialysis candidate, you tell them what the risks, the benefits, and most families are going to tell you this. Can we at least try it? we have nothing to lose, right? What I usually do in those cases when the family or the patient feels very strongly about trying to do everything they can to stay alive, I will offer dialysis, but I will give them limits. I'll say, fine, we'll try it for 2 weeks or whatever amount. And if there is no improvement within this time period, we're going to stop it. Because there's no point in continuing something that at the end of the day is not going to make any difference. Now, in the hospital, there's always the option of doing CVVHD, which is much slower and it doesn't cause those as much hypotension as intermittent hemodialysis. But again, you can't keep doing CVVHD on someone forever. Transplant is the way to go, as we've talked about. But now, the question you want to answer is, should you just transplant a liver, or should you also transplant a liver with the kidneys? And it all has to do with timing. Now, the transplant is currently the only definitive treatment that we have. Kidney function does improve afterwards, but it may never reach the pre-hepatorenal syndrome levels. So it does improve, but you are at risk for some chronic kidney disease, even if it reverses. Now, the 5-year graft survival is 10% lower in patients who had hepatorenal syndrome prior to their liver transplant. So their prognosis is not as good as a patient who undergoes liver transplant who did not have hepatorenal syndrome. Basically, what this is telling you is if you have hepatorenal syndrome and you get a liver, that liver won't survive as well as if you did not have hepatorenal syndrome and you just got the new liver because you have